All right, welcome everyone. If you're a neonatologist, a fellow, or a dedicated NICU professional, you already know that managing blood pressure in a premature infant is, well, it's arguably one of the absolute most daunting challenges we face at the bedside. Today's explainer is really a dedicated masterclass. We've put together a quick 10-minute visual reel commenting directly on the most current, high-yield data to help you navigate this incredibly complex landscape of neonatal hemodynamics. We're going to take all that dense pharmacological data and transform it into a dynamic, highly practical clinical blueprint. So let's get into it.
Okay, here is our roadmap for today. We're organizing our clinical journey logically. We'll start off with the ambiguous vulnerabilities of the neonate, move right into decoding what arterial pressure is actually telling us, unpack our vasoactive arsenal, talk through escalation therapies for those crashing patients, and finally, bring the whole shebang together into a precise, step-by-step bedside clinical pathway.
Section 1. Preterm cardiovascular vulnerabilities. To understand the solutions, we first have to acknowledge our baseline challenge, which is the structural vulnerability of the preterm cardiovascular system. We are dealing with a totally immature myocardium here. It contains only about 30% contractile fibers. Compare that to 60% in adults. It's disorganized, and it is entirely dependent on extracellular calcium. And on top of all that, these tiny hearts are battling severe transitional stress, hemodynamic shunts like a PDA pulling away diastolic pressure, and perhaps worst of all, dangerous receptor desensitization during sepsis or hypoxia. Honestly, the deck is fundamentally stacked against them.
Now, diagnosis is famously a moving target. You have overlapping variables like gestational age, absolute thresholds, like trying to keep mean arterial pressure above 30 in extremely low birth weight infants, and normative data percentiles. It is a notoriously gray area. But the clinical stakes, those are black and white. If we get this wrong, compromised cerebral oxygenation can lead straight to severe hemorrhage or death. Arterial pressure alone just cannot accurately indicate cerebral perfusion. Treatment absolutely demands a physiology-based approach, not just blindly chasing a numerical threshold.
Section 2. Decoding arterial pressure.
To truly decode those monitor numbers, you have to make a vital distinction. Low systolic arterial pressure literally cries out for contractility. It's indicating poor left ventricular output or cardiogenic shock, meaning you need inotropes. On the flip side, a low diastolic arterial pressure points to vasodilation, maybe from sepsis or PDA runoff, and that indicates a desperate need for vascular tone and vasopressors.
Think of this concept like a diagnostic dial. It visually shifts our focus from a single, confusing mean blood pressure reading to identifying the primary hemodynamic need. If your dial points to low systolic, your primary need is introps. If it swings to low diastolic, your primary need is vasopressors to restore that systemic vascular resistance. And of course, if both are low, we're looking at complex failure that requires really targeted combination therapy.
Using this pathophysiology-based selection framework builds our initial action plan. We're matching the specific clinical sign and disease state directly to its ideal pharmacological match. Got low systolic pressure with low output? You reach for dobutamine or medium-dose dopamine. Low diastolic pressure with vasodilation? You target norepinephrine or vasopressin. This mindset is incredibly powerful because it stops us from just guessing and instead links the underlying pathophysiology directly to the prescription pad.
Section 3. The vasoactive arsenal. Before we start looking at specific drugs, let's lock in the vital concept of an inodilator. This is a highly useful dual-action clinical tool. It boosts the heart's pumping ability while simultaneously easing the vascular resistance it actually has to pump against. It's basically like pressing the gas pedal while taking your foot off the parking brake. Now consider this matrix your ultimate cheat sheet. You might actually want to pause and screenshot this one. It maps out our core medications against their primary receptor targets and hemodynamic effects. You can see exactly how we categorize them, from pure vasopressors like norepinephrine targeting alpha-1 receptors to potent inoconstrictors like epinephrine, all the way over to pure inodilators like milronone. Building this mental model allows you to tailor your therapy to the exact receptor you need to stimulate.
Let's dive deep into our first-line workhorses. Notice how dopamine is essentially a sliding spectrum of variable action based on dosage. At 4 to 10 micrograms, it's mostly inotropic, but if you push it higher, it becomes a severe peripheral vasoconstrictor. Conversely, look at dobutamine. It maintains a targeted, super steady profile, acting as an inodilator to lower resistance while boosting output. The key takeaway here is recognizing the sheer unpredictability of dopamine
versus the steady, targeted action of dobutamine.
Now, those workhorses are great for initial stabilization. But what exactly is our next move when the incubator alarms are ringing, the blood pressure continues to tank, and the patient just isn't responding to your standard first-line therapy?
Section 4. Escalation and Rescue Therapies.
Our strategy for those critical moments divides perfectly. For cold shock, we deploy epinephrine as our adjuvant. It gives powerful contractility for inotrope refractory shock with low cardiac output. But beware, high doses can induce local tissue ischemia. On the other hand, for severe warm septic shock, we pivot to the massive peripheral vasoconstriction of norepinephrine, where the primary issue is dangerous systemic vasodilation. Norepinephrine reverses that low resistance without completely blowing out the pulmonary vascular resistance.
When adrenergic resistance hits and your standard pathways are totally exhausted, we can actually bypass those pathways entirely. We can use milrinone's lusitropic vasodilation for things like persistent pulmonary hypertension. Or we can use vasopressin. It stimulates V1 and V2 receptors to restore arterial pressure entirely independently of catecholamines. It's a fantastic clinical superpower to have in your back pocket when your primary receptors are maxed out.
But there's another layer to this nightmare scenario. Sometimes severe illness, hypoxia, or relative adrenal insufficiency causes complete receptor downregulation. You're left with a crashing neonate, blocked pathways, and perfectly good drugs that just have absolutely nowhere to bind.
This is where hydrocortisone comes in. It acts like a key, unlocking that blocked adrenergic receptor. We're using hydrocortisone not just as a general steroid, but as a specific receptor resuscitator. It acts via genomic and non-genomic mechanisms to rapidly upregulate those blocked receptors, usually within 2 to 4 hours, which significantly decreases the duration of vasopressor support you need. It essentially forces your catecholamines to start working again.
Section 5. The Bedside Clinical Pathway. We can break down the highly complex management of neonatal hypotension into these 5 clear sequential stages. By following these exact steps, you ensure that no vital diagnostic nuance or therapeutic intervention is skipped while you're managing a highly stressful code or stabilization. Mapping out that exact flow gives us a real-time decision tree. You start at step 1 with a functional assessment using echo and NIRS. Move to step 2 for careful volume expansion if capillary leak is present. Step 3 is selecting your first-line inotropes based on the pathophysiology we just discussed. If they're unresponsive, you hit step 4, assess resistance and introduce either epinephrine for cold shock or norepinephrine for warm shock. Finally, step 5 is your adrenal rescue with hydrocortisone. Seriously, print this protocol out and keep it in your pocket.
Of course, our job is never just about making a monitor look pretty, right? We are constantly weighing the severe risks of permissive hypotension, like uncorrected ischemia leading to neurodevelopmental impairment, against the very real dangers of aggressive, high-dose pharmacologic interventions, which can impair cerebral autoregulation themselves. The ultimate verdict is that individualized, targeted therapy is absolutely vital.
Looking toward the future of our field, we are moving well beyond simple blood pressure cuffs. The future is targeted neonatal echocardiography to measure actual left ventricular output. It's near-infrared spectroscopy, or NIRS, to verify that the blood pressure increases we force are actually translating to oxygen in the baby's brain. And fascinatingly, it's machine learning predicting individual responses to dopamine versus dobutamine with up to 90% accuracy based on patient-specific variables.
I'll leave you with this provocative final thought. A core philosophy to carry into your next NICU shift. True hemodynamic management treats the organ, not the monitor. So when the alarms are sounding, ask yourself, are you just chasing a number on a screen with heavier and heavier drug doses? Or are you looking at the actual physiology and truly perfusing the brain and organs of the vulnerable